बिस्मिल्लाहिर्रहमानिर्रहीम। अस्सलाम वालेकुम everyone. First of all, जो है congratulations to the Pakistan Society of Echocardiography and the role of Dr. Shehbaz and Tipu ji. They are taking it way forward. Society was there, but it was very dormant, and ultimately it slept for some time. And then these people were instrumental to revive it, and I hope that this will continue and grow further. Okay, see, the topic is very long, but I will try to cover it, most of it, common things. So there are a lot of pericardial diseases, and many of them have the role of echo, which is very important. If we go, what happens to the pericardium? There are three processes: the inflammation, which resulted into the fluid, and then finally the scar formation. And combination of these will result into, if inflammation only, the pericarditis. If there is a fluid, the pericardial effusion, fluid under pressure, tamponade, fibrosis, constriction, sometimes the mix of fibrosis and fluid, and there's the effusive constrictive pericarditis. We will try to touch on these things. I start with a case, very simple thing, like young lady, no cardiac risk factor, came to the clinic with some febrile illness and chest pain, and 3 days. Then characteristics of the pain are not typical of coronary, either the risk factors and the age of the patient. ECG has some changes, and echo with normal limits. So if there is a simple pericarditis, you do a echo and you may not find anything suggestive. So this is the clinical and the history. Pericardium is a layer covering, very thin, delicate layer, and when it is diseased, it will look like, and from here the process will start. So the pericardial effusion, the first thing, pericarditis, you will not get anything, maybe trace things. If you find pericardial effusion, so I go a little bit on the effusion. So every echo-free space anterior to the heart is not a effusion. So there are many other things like the pericardial fat, maybe thymus gland, maybe fibrosis. So every echo-free space, don't take it, this is a pericardial effusion. It can be, when it's effusion, it can be circumferential, it can be incysted, and a small echo during systole is also a normal. So systole, if you find something that we used to, people report trace pericardial effusion, that's a normal pericardial fluid. If you find in the diastole, then this is the pericardial effusion. And sometimes it's difficult, but it's important to differentiate between pericardial and pleural effusion. And the next thing is, when you measure it in the diastole and the width of the effusion, echo-free space, and then you categorize it mild, moderate, severe. So usually if it is less than, and take the maximum one, less than 1 centimeter mild, 1 to 2 moderate, and more than 2, this is a severe pericardial effusion. So these are the simple things. And if you see here, how to differentiate between pericardial and pleural effusion. And if you see, the key thing is that you see the position of the aorta. So the effusion which is in the pericardium will go anterior to the aorta, and which is pleural, it will go behind the aorta. And in other views, you will see also the same thing. And finally, here you have some pericardial effusion as well, so you can differentiate their positioning, that where they are. Then on severity, you will measure, okay, the width of the echo-free space, and according to the measurement, you will divide how severe it is. Then the same case continues, that you treated that patient with the non-steroidal anti-inflammatory drugs, and the pain settled down a little bit, but presented after 2 weeks to the ER with shortness of breath and dizziness. And there's a tachycardia, low blood pressure, chest is clear, GBP raised, and heart sound muffled. So in this case, when you do a chest X-ray, and you will find this chest X-ray, so you know that there's a large pericardial effusion. And then you will think about, okay, the clinical condition with this chest X-ray and prior history, this is the pericardial tamponade. So tamponade, we all know that this is the clinical syndrome, hypertension, tachycardia. And when the intrapericardial fluid pressure is more than the intracardiac, particularly right side chambers, then there is a pericardial tamponade, which is a life-threatening condition. So the tamponade, not necessarily a large amount of fluid, and you will find on the X-ray is tamponade. Tamponade is the pericardial pressure increase, and this depends on the how fast or slow the fluid is accumulated. The small amounts like the coronary perforation and small amount, and it can result into tamponade, and sometimes the hypothyroidism, large fluids there, and tamponade is not there. So number one, the rapidity it will accumulate. Number two, the amount of the fluid, and number three, the condition of pericardium, like constructive effusive. So pericardium is thickened, is stiff, so a smaller amount can give you tamponade effect. And this is the same thing, like the the rapidity of effusion. If you see in on this side, then this is the rapid effusion and little amount and quick rise, and here slowly developing effusion. It will take large volume to develop the tamponade effect. Then this is the concept of ventricular interdependence, and normally with the breathing, the flow remains same in the inspiration and expiration. It's not working. So you see the flow remains same, and lower down you see the inflows remain same normally between inspiration and expiration. If you see here, okay, the flow, inspiration, expiration both are same. So when there is the ventricular interdependence is lost, when the endocardial pressure is high, then during inspiration, this we are seeing the LA flow. So during inspiration, it will go down, and during expiration, it will go up. And same here, these waves will go down, and this is one of the echo features of tamponade. And this is the picture same. We are seeing the both on left and right side, same thing is happening. So we move to the echocardiography, and this is the M mode. And in the M mode, if you see that there is change in the cavity size here during inspiration and expiration, LV cavity size, and we will see further on different images. And this is the same effect. Like I used to say to my student that septum is like a husband. Okay, it's in between the mother and the wife. And one pressurize, it will move to the other side, the other pressure to other side. So this depends on during inspiration, the RV is pushing it to the LV, and during expiration, it's the other round. And this movement will change the flow and will change the E wave velocities and give us the okay. So ventricular interdependence, septal motion abnormality, mitral flow velocity variation, pulses paradoxes, and it increase with increased respiratory effect. So it's not always tamponade. It's not always when you say it. So COPD, obesity, asthma, sleep apnea, or there are other conditions which can give rise to this variation. So cardiac tamponade effect, echo, what you will see, the IVC will dilate, will not collapsing. This is the earliest sign. And then there is variation in mitral and tricuspid velocity, which is 25% and more in the mitral and 40% more in the tricuspid. Later sign are the RA and RV collapse, and very late sign is LA and LV collapse. So we will see some examples of these. So here you can see the effusion, and you find that this is the LA, this is the RA collapse, and you find it, and RA collapse in the late diastole, because that's the time when the pressure in the RA are lowest. Similar thing you see in the different view here, very clearly you can see the collapse. Then you go to the RV collapse. This is a very good sample of RV collapse, and you will find, you focus on this RV, and you see the wall that it will collapse. So during systole, it will go in, and it will not come back quickly. It will take time. That is, and it is in the when the RV is empty, it's the late diastolic, early diastolic collapse. So it's when the RV pressures are lowest. Same thing on the M mode, the collapse, if you are not able to appreciate. So M mode has a very good temporal resolution, so you can get a M mode, and you can easily see this. So I skipped this one because for time. So this is the mitral inflow pattern, and you see the EA waves are not much different in tamponade as compared to the other. These are the variations you see here. Respiratory variation. Ideally, you have to have a respirometer, but you don't have like this respirometer. You need to see But if you don't have, then at least in the right clinical setup, you can see. The hepatic vein Doppler in the tamponade, the forward flow, diastolic forward flow is gone, and there are reversals. And then you have LVOT variation. I'm skipping this in the interest of time. There one of these interesting things. And and you move here, and you can appreciate in the next picture more that there is it's not working. There is LA collapse. You see the LA collapses. So this is the late sign which is here. I want to show you, and sometimes you have a large fusion swinging movement, and you see here swinging movement, and you see this pulses alternance on the ECG, and then cardiac tamponade. Right side chamber compression is specific but not specific. If right side pressures are elevated, then it will not happen. And the Doppler findings, yeah, they comes early, more sensitive but less specific. And these changes are similar in the constrictive pericarditis, but E wave, E prime will differentiate. So if you don't diagnose tamponade right time and treat, this will happen. Move to the next case, 55 lady, seen the clinic with the history, pedal edema, dyspnea, exertion, examination, markedly elevated JVP, pedal edema, ascites, echo advised. And you find the echo where the atria are dilated, the LV function is normal and restrictive filling. So there is a dilemma that is constriction or restriction. So I'm going to discuss it. So it's no more a dilemma, and with the arrival of newer modalities, it can be easily done. So how you proceed? Left and right heart cath, CT, MR, or more information echo. So what are the different things? Pathophysiology, I'm speaking for the time of interest. I'm going here. I've already discussed signs of ventricular time. Signs of ventricular interdependence, pericardial thickness, and condition of the myocardium. So if you do a CT, you will see the thickness of the myocardium, and we know that it's not necessary to have a thickened myocardium for the constrictive pericarditis. If you go to the MRI, that's a very good modality, and you see the interventricular interdependence. You see the breathing and the septal movement. You see here. You can see the calcification here. You can see the calcification here and septal bounce here. So it's a very good modality, but the problem is it is expensive and not really available. Catheterization, you see these numbers only, like the negative and positive predictive values. So only one thing, which is left and right pressures, will tell you. Otherwise, it's not useful. It's this. So I'll move it to the echo signs. So if you see, same is like the M mode, and there is the respirometer, and this is the inspiration, this is the expiration, and there's a change in the septum movement. I saw better images there. You see, concentrate on this image, septal shift. Okay, so with the breathing, you have to take a multi-beat image, and you see that septal shifts on the left side, on the right side. So this is a very important finding if you get this. There's a similar thing. There is change in the velocity, and there's again a respirometer. And then you see the hepatic vein Doppler, and hepatic vein Doppler, again, respirometer is important to know that there is a reversal in which phase, the expiratory phase. This is the real Abrar image. Move forward, additional echo features of CPC. Okay, so this jerky movement, okay, of the septum, which you see here, it is equivalent to the square root sign on the cath. Then annular paradox means that there is restrictive filling, but the E prime is good, and if you see the E to E prime ratio is 5. The paradox, the LV filling pressure is elevated, but the E to prime ratio is low. And the TDI will differentiate constrictive, restrictive. The cutoff value is 8. If it is less than 8, it is restrictive. More than 8, it is constrictive. And this is the study which is showing this thing. Then this is pericardial thickness. We have already done. You take the M mode for the pericardial thickness. And if you apply the multiple modalities of the echo, like the A is the hemodynamic, hemodynamics you apply. So this number is there. If you apply the Doppler as the 2D echo and M mode, and if you apply the TDI, so if you use all three, you see the sensitivity and specificity of the echocardiography is very high.